Hi, everyone. This lecture is going to be about 68-year-old female with altered mental status. So thanks to Dr. James Choi, Dr. D'Souza, and Dr. Kim for their help putting this together. All right, so our patient is a 68-year-old female. She was called and is a pre-notification for stroke. Her last known well was 2 a.m. There was concern for altered mental status and facial droop by her by EMS as well as her daughters. Patient was brought in around 3 p.m. And so her initial vitals, initial vitals, she's 154 over 138. Heart rate's 124, respiratory rate's 24. She's afebrile. Her airway's intact. She has bilateral breath sounds. She's normotensive, tachycardic, and has distal pulses intact. And so she's awake, alert, following some commands, but not really speaking. She's globally weak, but no facial droop was noted by our ED team. And so a stroke code was initiated. Her past medical history from speaking with her daughters and chart review had she had a meningioma, had a history of migraines, and has obesity, was on a GLP-1 agonist at home, has no known allergies. So the stroke code was completed. Just briefly, there was no findings on her CT or CTAs that were done. There were no specific neurodeficits other than her altered mental status and her kind of inability to participate fully in the exam that was noted by our team or neurology. And so the patient was reassessed when she came back from CT by our ED team. She had a heart rate of 110, but she was now hypotensive to 104 over 84 and now febrile to 102.7. She remained altered, not verbal again, but she was alert. She didn't have any nuchal rigidity, but still globally weak. Lungs were clear bilaterally. Heart sounds were normal. Her abdomen was soft, but had some suprapubic tenderness. There were no noted skin changes, no ulcers or breakdown, no sort of explanation so far, or no clear explanation for this fever that she had. So any thoughts on initial interventions from our junior residents? Yeah. Okay. Well, sorry, I can't see the chat, so I don't know if any. Oh, there it is. Okay. Yeah, fluids. Yeah, great idea. So fluids, antibiotics, great. So, kind of our we basically, or not we, I wasn't there. This is a case that was in our ED. So patient was resuscitated with a 30 cc per kilogram bolus. Started on broad spectrum vancomycin and piptazo. Given we didn't know her, they didn't know her source yet. She was given antipyretics and an EKG and point of care ultrasound were initiated. So does anyone want to interpret the EKGs or anything interesting on here, or what do you think?
Alex, what do you think?
Me? Okay, well, its normal axis rate looks to be about 100. In terms of it's regular. The PR interval looks normal. I don't see a super wide QRS. The QT looks a little bit long to me. I see some like S waves in the anterior leads. I don't see any like ST elevations or depressions. The P waves all look like they have the same morphology to me. I don't think I see signs of like atrial enlargement. Yeah, so I think those the only abnormalities that I see is like maybe some S waves in the anterior leads and a bit of a long QR or a QT.
Great. Yeah. So this is pretty not super exciting EKG. We have a normal sinus rhythm, maybe mild tachycardia, but otherwise not really giving us an explanation for what's going on or anything further that we want to dig into from my perspective. All right, so given the patient's abdominal pain, the team did a bedside sono. So does anyone know what this looks like, and what would you do for this? What would you do for this patient at this point?
It looks like the bladder, the patient may be in urinary retention. You could put a Foley in it. It looks if it's like over 300 to 400 cc's, which it looks like it is.
Yeah, no, exactly. So I couldn't quite catch the image. I guess we fanned through. We could see this. So the team placed a Foley and with a return of about 1,000 cc's of urine. So let's go through our active problems so far. If you guys want to just kind of put in the chat or shout out any active problems that have come up so far. Excellent. Yeah. So I'm saying fever, hypotension, and urinary retention. Exactly. And so I'm actually going to skip ahead to our labs because I wanted to show you those. So what are sort of your so here's kind of an initial set of labs for this patient. So anything kind of jumping out as abnormal. I know it's kind of a lot to look at, a lot of red, but anything jumping out at you guys? Yeah, so patient's hypokalemic, yeah, has a lactate, has an AKI. AKI is kind of the ratio is about 10, the BUN creatinine, which sort of indicates maybe a obstructive pattern, but those aren't always super reliable. But we also know that our patient was retaining, so that could be an explanation. Right, and can do that. Patient has transaminitis. So we can kind of add some of these findings to our problem list. Patient has an AKI, has an acute liver injury as well. We don't really have any baseline information. Patient's hypokalemic, doesn't have a white count, and hemoglobin's normal. Platelets are relatively normal. It's 141 though, so they're a little bit low. All right, so kind of given all these problems together, what's sort of your differential for this patient so far? We've got sort of a lot of different things going on, but yeah, sepsis is there's some kind of sepsis going on. Anything else that could be any urosepsis? Sure. So far, what do we think some of our sources could potentially be based on how this patient looks so far? She's altered, she has abdominal pain, and those are kind of our only sort of objective findings so far. Sure, there certainly could be Neisseria water experiencing syndrome. Yep. Anticholinergic, yeah. Pyelo, exactly. Exactly, yeah. So here's some additional, oh sorry, we already threw those up. So here's her urine. So her urine, not so exciting, just some red blood cells, but pretty much a negative urine. So no real infection. That's not really our source for her sepsis. Her viral swab's negative. And there's some coags in here that are pretty normal, maybe some mild elevation. I had a troponin in here at some point, but it mysteriously disappeared after Dr. D'Souza reviewed our slides. So, but that was also not thought to be explaining anything that's going on right now. So, so that's kind of the rest of our labs. So here's our chest X-ray for this patient. She's been saturating well on room. Well, she's had intermittent hypoxia, but no increased work of breathing. There weren't any noted findings on her lung exam by the team or that was documented. But this is her chest X-ray. Does someone want to sort of interpret this X-ray for us? Yeah, definitely. I mean, it looks like maybe there could be a little bit of fluid. I see a little bit of like maybe opacity in the right on the right lower. No, I don't see anything very clear, but this was the official read was on this was maybe some right lower opacity, but nothing really specific, no large consolidation. Certainly maybe could be a source for her, but it's not very clear, and she's not really having any respiratory symptoms. All right, and so from chart review, the patient had some transient hypoxia during her ED course. So a CTA PE study was obtained. So there wasn't really like I said, there wasn't any documented wheezing or increased work of breathing, and so I'm not actually clear if there was no like arterial blood gas from the ER, because when were we going to do that? So it's unclear if the patient was truly hypoxic or if there were maybe inaccurate pulse oxes because she was starting to perfuse poorly. Regardless, the CTA was negative. She also had no source for her sepsis at this point. Her UI was negative, and she was becoming more hypotensive. And so they did a CT abdomen pelvis, and she had tenderness to palpation there initially, but there was really nothing acute on her CT abdomen as well. Right, so patient's reassessed. So now she's become more hypotensive. She was initially responsive to fluids, but now her blood pressure is 79/52. Heart rate's 98. She's saturating well. Temperature's down to 99.8. She's had 3 liters of fluid, but she's remaining hypotensive. And so peripheral levofed was started by the team, and a central line was placed. And so after the central line was placed, I was told that this was sort of a dramatic unveiling where they took the drape off after placing this flawless central line and noticed this new rash on the patient. So any thoughts on what this rash might be? Yeah, definitely. It looks like purpura. Anything else it could be? Yeah. So like TTP, and so DIC, yeah. Because we already know this patient is in septic shock. DIC with gram-negative bacteremias can be common. It could also be a vasculitis. The patient has no history of autoimmune disease, but that certainly is still on the differential. We still don't have a lot of information. But the patient's platelet count was 140 when she first came in, but we are concerned about DIC. She's kind of getting progressively more ill over the first couple of hours she's in the ER. Right. So based on these sort of findings so far, so we have a septic patient that we don't have a source for yet, and now has developed this purpuric rash. Which is not blanching. Based on these findings, what would you pursue next? Are there any consults that you want? Yeah, MICU for sure. Yeah, this patient's not going anywhere except for MICU. And any other consultants that you want to get on board? ID, sure. Yeah, hematology. So we're dealing with a rash that we think is purpura. There are multiple etiologies of purpura, even within sepsis. So the team actually got a hematology consult in the ER, and they called dermatology as well. I think they saw the patient a little bit later. An ID was later consulted when the patient was in the medical ICU. So hematology saw the patient before admission to MICU and said that TTP was certainly a concern, but the plasmic score for TTP was low. They looked at the smear and said that they didn't really see kind of the typical findings you would see in TTP. And they think that this was likely DIC with Purpura fulminans. Dermatology kind of agreed. They said, sure, it could be a vasculitis, but we really do think this is Purpura fulminans, secondary DIC, secondary to the patient's sepsis. So they did do a biopsy because the biopsy would help them sort of differentiate whether this is a vasculitis versus Purpura fulminans. And so patient was admitted to the medical ICU. We'll kind of go into that a little bit more. But in terms of the patient's ED course, so just to kind of review, so the patient came in hour 0, presented with altered mental status, tachycardic, but normotensive. Stroke code was called by the time the patient really came back from CT, became febrile, hypotensive, was fluid resuscitated and given broad spectrum antibiotics, but then had the transient hypoxia, had a PE study and a CT abdomen pelvis that were negative for any acute pathology. Bedside sono showed a distended bladder. They placed a Foley, and then found a few hours later that her hypertension was no longer fluid responsive, and so she had a central line placed for Levophed, and then she developed this rash. Hematology around hour 8 advised this was likely Purpura Fulminans, and she was initiated on a heparin drip, and then she was admitted to the medical ICU for concern for for TTP versus HUS versus meningococcemia versus listeria infection. It hadn't really been fully elucidated what we're treating here, but this patient is very sick. And then I'll just give you one slide on the patient's early MICU course. So basically within 24 hours, our blood cultures grew out that we were drawn initially in the ER, positive for Neisseria meningitis. So this patient has meningococcemia. So I just want to talk a little bit about meningococcemia, DIC, and Purpura Fulminans. This is, I've never seen a case of Purpura Fulminans in our ER or in medicine. But it is a very interesting presentation. It's kind of a subtype of DIC that is highly associated with meningococcemia, and that was seen in our ER here, and so we definitely all could see one there. So I'm just going to kind of go through some of the kind of high level points about prothrombotic versus coagulopathic DIC, some of the lab findings in DIC. There is a score that that we can use. There are several scores, but some that are utilized a little bit more frequently to sort of determine whether a patient is in DIC or at least give us some clues on how to sort of characterize it. And then I'll kind of go into how we diagnose and manage Purpura Fulminans. It is something that in the ER we want to sort of get ahead of before these patients will ultimately go to the ICU, just because of the ultimate risk of skin necrosis and the high sort of morbidity for these patients as they are also in a septic shock. So there are basically two components of the pathogenesis of DIC. One's the coagulopathic component, which sort of occurs through activation of the intravascular coagulation, which ultimately leads to a decrease in platelets, fibrinolysis, which increases your D-dimer, an increase of PT and PTT given coagulation factor consumption, which ultimately leads to the bleeding that we talk about in DIC. And there's also kind of the prothrombotic arm, where because it's kind of initiated by this endothelial damage, which leads to microvascular thrombosis. So you can kind of throw these tiny clots everywhere and leading to multi-organ ischemia and failure. So just to kind of go through some of the lab findings in DIC, so for your CBC, you're going to look for thrombocytopenia, which is very sensitive but not specific. In this patient, she's certainly in DIC, but her platelets were pretty normal to begin with. They were a little bit low. We don't know what her baseline was, but you know, they weren't 30. They were, you know, in the 100s. And so something to sort of keep in mind when you see low platelets, but not having low platelets, it doesn't exclude the diagnosis. And with patients in terms of their coags, you can have, again, elevations in these can support a diagnosis of DIC, but they can also be normal, actually in over half of the patients with DIC. In terms of your fibrinogen, I think we talk a lot about fibrinogen being low in patients with DIC, but I think it's important that a lot of our patients in the ER that we see with DIC are going to be our septic shock patients. Like, we're not getting OB patients after, you know, hemorrhage during delivery and that kind of thing. And so fibrinogen is also an acute phase reactant. And so early in kind of their septic shock course, it's going to be elevated. And so it's not going to be as reliable as an indicator of DIC in a lot of the patients that we see, but trends in sort of fibrinogen might be a little bit more helpful if we kind of find it trending down after you hit that, hit a certain peak during their sort of acute sepsis presentation. And a D-dimer is going to be elevated in a patient with DIC. So one commonly used score that we use for DIC is this ISTH score, and a score of greater than 5 is positive for DIC. And so for our patient, hematology actually in their note at hour 8 calculated a score for our patient, and they calculated it to be 6. This score is really, it can be helpful, you know, along with sort of the clinical picture of the patient, to kind of see, you know, it doesn't, again, a score of less than 5 doesn't exclude a diagnosis of DIC. It's still very much a clinical diagnosis, but it sort of helps you start thinking about the right things, that we're like, okay, what range are our platelets in? Oh, we have a mild elevation in our INR, but that actually does give us 1 point. And I think sometimes when we look at coags and we see mild changes and then early on in a course, we may not sort of register them as being abnormal when we have so many other things going on, especially if we didn't see that rash right away. But those labs were abnormal from the beginning. But I know personally, if I saw a INR of 1.4, I wouldn't get that excited. But in this patient, it actually ended up being significant. Regarding Purpura fulminans, so this is a clinical diagnosis. So about 20% of cases of Purpura fulminans are associated with Meningococcemia. And so like we talked about, biopsy can be done to differentiate if Purpura is caused by vasculitis, where the microvasculature, is becoming inflamed and bleeding into the skin, versus microthrombi in DIC, where you're basically getting like infarction. And so underlying Purpura fulminans is caused by protein C deficiency. So it can be congenital or acquired, but obviously in the case of sepsis, it's acquired. And so if you recall from learning about kind of the coagulation cascade and everything supporting it, protein C is essential for the formation of the anticoagulant complex on cell surfaces. And so it works basically by selectively inactivating factors 5 and 8 so that you are able to achieve anticoagulation. And so when we don't have it, we end up in a prothrombotic state. And so there's a couple of components of management of Purpura fulminans I just want to discuss. This is basically how do you address their underlying septic shock. There are some kind of important considerations in patients who present with this specific finding, and their underlying protein C deficiency, the fact that they may also be coagulopathic at the same time, and you also maybe want to stop them from throwing clots everywhere. Ultimately, a lot of these patients have skin necrosis that also needs to be managed. So a couple of considerations for dealing with the septic shock in a patient with PF. So for your antibiotic selection, you actually want to initially dose broadly because I think this patient presented at hour 4 with this rash. The patient had already gotten antibiotics. We want to, as soon as we know the patient is septic, we're giving antibiotics. And so starting with vancomycin and piptazo is very reasonable, and it's a good choice for the patient, especially when we don't know what's going on yet. Just knowing that the most common infection that's associated with PF is meningococcemia, it's not a bad idea to go ahead and start giving meningitis dosing if you have a high suspicion that that's what this rash is. Certainly biopsy could be pending and all of that, but all that's going to take some time to come back. But if you have a high suspicion, treating with kind of the ceftriaxone 2 grams Q12 is sort of the meningitis dosing, and so it's reasonable to start that. In terms of your vasopressor selection, you actually want to avoid Levophed as your primary pressor, which is very kind of counterintuitive. It's usually our go-to. It's a very good pressor in a lot of ways, but it also has alpha-1 activity that's going to cause vasoconstriction. And in a patient that is already having difficulty kind of perfusing their extremities because of the microthrombi that they're throwing, you may actually cause more vasoconstriction. In practice, I don't know that we would really start to choose epinephrine over Levophed in these patients, but it's just something to think about, especially if we have a very high suspicion that the patient's throwing microthrombi. And then in terms of stress dose steroids, so there's a lot of evidence for stress dose steroids now in severe sepsis, in septic shock refractory depressors, because patients may have a secondary adrenal insufficiency. But the reason to give stress dose steroids in these patients is actually twofold, because one, because of the septic shock, but also because The microthrombi can cause adrenal infarction, hemorrhage, so Waterhouse-Friderichsen syndrome. So giving early hydrocort, it can be very helpful for these patients because we can almost assume that they're going to have some adrenal insufficiency and not really respond to our pressors very well. And so this patient was given hydrocort 100 in the ER, which is usually kind of our starting dose we hit people with. And then you can, as you want to give stress dosing when the patient's in the ICU, you'll transition to 50 Q6. Okay, and then so these patients who have Purpura fulminans, they need to be anticoagulated. And so you will typically use a heparin drip. In these patients, PTT is not very reliable, given kind of the coagulopathy as well as the thrombosis going on. And so you actually want to titrate to an anti-factor 10A level that'll actually be a little bit more reliable. And so getting that sort of right off the bat to have some baseline in the ER can be helpful. One thing that I came across that I thought was a comment that I thought was interesting was just to avoid warfarin in these patients, because the mechanism of warfarin-induced kind of skin necrosis is the same sort of mechanism of the patients with PF, where you have early inhibition of protein CNS. I don't think in practice it's that helpful. I don't know anyone who like reaches for warfarin when you see a patient that needs to be anticoagulated, unless there are specific circumstances where they cannot be on a DOAC or anything like that. But these patients should be on a heparin drip. But I just thought that was interesting. And these patients also may need coagulation product replacement, but that shouldn't stop you from putting the patient on a heparin drip, because they need to be anticoagulated to kind of prevent some of these microthrombi from causing more issues. And so you can basically replace coagulation products as you continue to anticoagulate this patient. So you're going to give cryoprecipitate to a target fibrinogen about greater than 80. And you want to get your platelets to about at least like 30,000 if your patient's going to be on the heparin drip. And there's been some research and some practice on replacing protein C, because that is our underlying problem here. That's why we have clots, because we're not able to anticoagulate. And so there's sort of two different ways this could potentially be addressed. One is activated protein C. It's not currently on the market. There was some high risk for hemorrhagic complications for it, and so it's not really available, but it's something that's kind of been studied. And Saprotin is actually it's like an adjunct, like a protein C replace, I guess, is a protein C concentrate. And so there hasn't really been any RCT evidence showing that it improves outcomes in morbidity or mortality for like limb sparing or in mortality for patients with Purpura fulminans. But there have been some like kind of promising studies showing improvement in some of the hematologic endpoints, like protein C activity, lowering their D-dimer, increasing fibrinogen, and antithrombin 3. So theoretically, it could be helpful. It was considered by hematology in this case, but they ultimately opted against giving this to the patient and just said anticoagulation was sort of the mainstay of treatment at this point. And then lastly, just for PF management, these patients have pretty significant skin necrosis. And so they can have, it can happen pretty rapidly. They can have poor perfusion of their extremities. They can lose digits and that kind of thing. And so you could also develop a compartment syndrome. And so kind of one of the things I came across was that some sources kind of recommend using a peripheral vasodilator, like doing like topical nitro to sort of open up those vessels, which I think the first time I read that I thought that sounded kind of scary, because you're also dealing with a patient who's in septic shock, and so it's definitely sort of a risk benefit if the patient's blood pressure can tolerate having some topical nitro. It's something to think about to sort of prevent that digital ischemia, because they are at risk for sort of losing digits at that point. So just a little bit more about this patient's inpatient course. So like we talked about on day 2, this patient's blood cultures glue Neisseria meningitis, sorry, and was started on ceftriaxone 2 grams Q12 and started on hydrocortisone 50 milligrams Q6 for Waterhouse-Friderichsen syndrome. On day 4, the patient actually became altered, but even though her pressor requirements were had been decreasing at that point, it's a little bit unclear just from the documentation why she became so altered, but she was intubated that day just for airway protection. It sounds like no sort of respiratory reason for intubation. But by day 8, patient was improving clinically significantly, and her DIC had resolved and her heparin was discontinued then. So later on in the hospital course, the patient developed Acinetobacteremia. There was concern for vegetation on TTE. She was transferred to Bellevue initially for TEE, but they didn't find any endocarditis, and she was transferred to medicine 24 days after she was admitted to the ICU and discharged to subacute rehab about 2 weeks later. So this is a picture of the patient about 3.5 months after her initial presentation. This is taken in a dermatology clinic. So she still has pretty, she's recovered, pretty fully in terms of her sepsis, but she does still have some skin necrosis. They're talking about different options for debridement. They said they're trying to avoid, in their notes, trying to avoid amputation, but these are some of the sort of lasting effects of having this kind of prothrombotic DIC picture in this pretty sick patient. So there's a couple of take-home points. So this patient, I think this patient came in with really non-specific sepsis, and it's a lot of our patients, right? And so we typically will give broad spectrum antibiotics, and it's the right call. And I think when we want to sort of consider Neisseria meningitis treatment early when suspicious for Purpura Fulminans. So this patient got they got blood cultures drawn, and then they ultimately grew out the first day of admission. And then in the MICU, after they'd been admitted for about 12 hours, then their antibiotics were switched to ceftriaxone 2 grams Q12. So it's something that if we haven't had suspicion, it may be helpful to kind of increase our dosing. The patient had gotten a lot of antibiotics. They had gotten cefepime, flagyl to kind of cover. We didn't really know there was a suspicion for meningitis, meningococcemia on admission, but there's sort of nothing wrong in throwing meningitis treatment early on if we're worried about it. And then patients with PF should be anticoagulated on a heparin drip. This is one of the very I think maybe the only situation in DIC where we're going to anticoagulate a patient. And then as we talked about, we're going to use a factor 10A level to titrate our heparin drip, and replete coagulation products as necessary. There is some evidence there is saprotin in acquired protein C deficiency, but it might not be widely available. But it's something to kind of consider, especially as there's more research on this product replacement. It might actually be what turns around these patients more quickly than just anticoagulation. And then I would also just consider an early consult to trauma, burn surgery, just given the rapid skin necrosis that happens for these patients, to see if there's anything that they can offer as we're sort of treating the underlying medical cause of all this necrosis. And that's all I have.